Hello everyone, this is Karine Haas. I'm going to be presenting the clinical practice guidelines on the management of total knee arthroplasty. This guideline was released earlier this year in February of 2020. So the purpose of this CPG is to help improve treatment based on current best evidence. It contains a systematic review on studies published between 1995 and 2018. This includes where there is good evidence, where evidence is lacking, and topics for future research to improve management. This is for the management of adult patients with knee osteoarthritis and undergoing primary total knee arthroplasty. It's not intended for the revision or partial knee arthroplasty, pediatric patients, or patients with rheumatoid arthritis. So I'm just going to be breaking down several of the recommendations that are listed in the CPG. I figured that there were some components of the CPG that was not related to outpatient orthopedic management. So I decided to skip over those, but you're more than welcome to look back at those, look back at the ones that I am not going over today. But I will be talking about the preoperative exercise program, the preoperative education, cryotherapy, motor function training, post-operative knee range of motion exercise, neuromuscular electrical stimulation, resistance and intensity of strengthening exercise, prognostic factors, post-operative physical therapy supervision, and outcome assessment. So to begin with preoperative exercise. The recommendation is physical therapists should design preoperative programs and teach patients undergoing total knee arthroplasty to implement strengthening and flexibility exercises. So again, this is when we are educating our patients and bringing them through therapy in order to strengthen and increase their range of motion prior to undergoing this intensive surgery. The evidence quality for this is very high and the recommendation strength is moderate. There were 4 high quality studies that the CPG included, as well as 2 moderate quality studies that support the use of preoperative physical therapy training and exercise programs for patients who are undergoing TKA and are associated with better postoperative functional outcomes. According to WOMAC scores, TUG scores, knee flexion and extension range of motion, hip and knee strength, they all improved at 1 and 3 months post-surgery with preoperative training. In future research, the research should examine specific regimens or recommendations for the type and frequency and duration and progression. We should consider patients as candidates for preoperative exercises. So I've listed the benefits of having preoperative exercise prior to surgery. That included improved activities, decreased pain, improved balance. It improves knee flexion and extension range of motion, improved hip and knee strength, and reduced length of stay. The CPG did not report any harms were associated with this recommendation. So as well as preoperative education. So it's recommended that patients should be provided with preoperative education before undergoing TKA, and including an at the minimum patient expectations during the hospitalization and factors influencing discharge planning and disposition, the post-operative rehabilitation program, safe transferring techniques, use of assistive devices, and a fall prevention. So for this, they said the evidence quality was insufficient, but the recommendation strength is because of best practice. There's not that much research going about how to effectively provide information to patients, but it is important to let them know all the different expectations when going into the surgery and what might happen after. They believe that, it is supporting the best practice, and it is a recommendation that we should be instilling within our practice in all settings. This increases patient-centered care. They also saw that there was a closer match between expectations and the information given. that there would be more satisfied patients that were happy with their care. But they, however, suggested that preoperative education did not completely fulfill patients' expectations, and that postoperative education was also important. They also found that it could be useful treatment in adjunct to people who might have depression or anxiety or unrealistic expectations. So again, it's all about educating the patient about what to be expecting with this surgery. Next is the treatment of cryotherapy. So the recommendation is physical therapists should teach and encourage use of cryotherapy for early postoperative pain management for patients who have undergone TKA. The evidence for this was very high, and the recommendation strength was moderate. The CPG describes modalities such as ethyl chloride spray and continuous flow cooling devices. And although we don't use that in our clinic, there were studies that they covered that evaluated cryotherapy devices versus just standard cold packs for pain management, and they found no statistical significant difference. So when we're discussing with our patients after having a total knee surgery, that it is okay to use ice, regardless of what modality they might use in terms of using a cooling agent. A standard ice pack is fine, and the benefits is that it improves pain management and it's very low cost. Again, the CPG found no difference in the rate of the adverse events between groups who had a control versus having the cryotherapy treatment. They did mention that for further research that it should be focused on the frequency and use and the length of time the cryotherapy is used post-surgery, as there's insufficient evidence to identify how many days post-surgery the cryotherapy should be continued. Next, we'll talk about the motor function training. PTs should include motor function training, as exemplified by balance, walking, or movement symmetry for patients who have undergone total knee arthroplasty. So again, the evidence for this is high and the recommendation strength is strong. The types of interventions they included were the types of interventions that this studies included were not limited to were dynamic balance training, robot assisted gait training, movement training with visual biofeedback, and this was all to promote weight bearing symmetry and motor function training overall. They found that balance interventions were improved. The balance interventions improved walking function as measured by gait speed, stair climbing, the tug test, and all of this was improved after 32 weeks of training. And they also noted that after 9 months of training, that there was an increase in the 6-minute walk test. But given the varied nature of the study interventions, the group decided that they cannot recommend a single post-operative movement training program, but they, however, had exercises that promote dynamic balance and movement symmetry appear to be appropriate. So again, this improves your balance, improves the walking, improves, outdoor activity, outside of therapy activities such as getting in and out of cars, shopping, and doing their household duties. They did not find any risk or harm associated with this recommendation. Post-operative knee range of motion exercises. The recommendation is physical therapists should engage and teach patients to implement passive, active, assisted, and active range of motion exercises for the involved knee following a total knee arthroplasty. It was noted that preoperative knee range of motion is positively associated with postoperative knee flexion in patients with severe to moderate knee flexion contractures. Preoperatively may have a greater risk for postoperative knee flexion contractures. So again, they were just enforcing within the article that we should be encouraging our patients to go through knee range of motion exercises to avoid any contractures. or any decrease in range of motion and avoiding stiffness. But despite the lack in quality of evidence, the group felt that it was compelled to make a strong recommendation to support the use of range of motion exercise as this is best practice and to keep our patients functional following this surgery. They did not expect any risk with this recommendation, but they did mention that we should be aware of any complications after a total knee arthroplasty that might affect exercise, including scar healing, swelling, inflammation, and things of that nature. Next is neuromuscular electrical stimulation. Again, I know this isn't something that is utilized in the clinic, but it was something that I saw that was very highly recommended and had a large strength in moderate strength suggestion. The recommendation was that physical therapists should use NMES for patients who have undergone TKA to improve quadriceps strength, gait performance-based outcomes, and patient-reported outcomes. There were 2 high-quality studies that were found in this article that improved quadriceps and hamstring muscle maximum voluntary isometric contractions from 2 to 52 weeks following a total knee arthroplasty. There were also 4 high-quality studies that reported greater improvement in walking, stair climbing performance, and patient-reported outcomes with an NMES use compared with no NMES use from 2 to 52 weeks after a total knee. So I figure that this would actually be something that if we have patients who come in and are having a quadriceps extensor lag or decrease in quadriceps activation, that the NMES should be applied as recommended from the CPG for at least 3 weeks. They did mention in the article that additional research has to continue to refine how to figure out the optimal dose and the stimulation parameters in the application with and without muscle contraction in order to make sure that we are utilizing it to its full potential. But like I mentioned before, the benefits are that we are getting that voluntary contraction anywhere from 2 to 52 weeks after the total knee surgery, as well as improving their overall functional ability with walking and utilizing stairs. The risks that was associated with this was a decreased tolerance to using NMES, pain or discomfort, and also the cost and the utilization of it if there is lack of availability to the clinic. Next, I'm going to talk about resistance and intensity of strength in exercise. This was a high evidence quality, and a moderate recommendation strength. The recommendation is that physical therapists should design, implement, teach, and progress patients who have undergone TKA and high-intensity strength training and exercise programs during the early post-acute period to improve function, strength, and range of motion. I know that we always use strength and conditioning protocols when we are working with our patients. This CPG kind of geared it towards utilizing at an early stage, more when they're in the acute setting versus when we're an outpatient. But the article did a good job of mentioning that one of the studies found that post-operative resistant training at 8 weeks resulted in higher levels of functional mobility and better knee extension and range of motion. But it was found that patients with large muscle activation deficits might not experience sufficient muscle overload with resistance training to achieve comparable strength gains as those of patients without muscle activation deficits. So, with that being said, that kind of related back to utilizing the NMES device with these patients in concurrent with their strength routine. The article did mention that because there was a variety across all the studies that they included, that they were unable to have direct parameters for the training. But they found in two studies that with 6 weeks of progressive resistance training 3 times per week, starting the day after surgery, resulted in better balance outcomes. And in another study, that resistance training 3 times per week for 8 weeks, initiated 8 days after a total knee replacement, resulted in better muscle strength, and that those gains persisted through 12 months after the total knee replacement. So again, we all know the benefits of strengthening and exercise is to improve muscle strength, improve the activities related to their mobility, improve their balance, improve their knee extension and flexion. They found that early training does not have any risks. Otherwise, with that they didn't see any risk with appropriate progressions, but otherwise it can exacerbate pain and swelling if not done correctly. All right, next I'm going to talk about prognostic factors. So the physical therapist management should take into consideration the following factors when determining prognosis, treatment, and informed decision making and expectation setting with patients undergoing total knee arthroplasty. So they covered several different prognostic factors. Again, this is not all, but this was just some that they covered within the article. So that would be BMI, depression, preoperative range of motion, preoperative physical function, age, diabetes, degree of comorbidity, and sex. The article discussed that patients who have a higher BMI is associated with a more post-operative complication and worse post-operative outcomes. They also mentioned that depression is associated with a worse post-operative outcome. They talked about preoperative range of motion is positively associated with post-operative range of motion, but has minimal, if any, effect on physical function and quality of life. They also said that the preoperative physical function of a patient is positively associated with post-operative physical function. They did mention that age is a factor related to worse patient outcomes within 2 studies, and indicated a negative effect on impairment level outcomes of gait speed and knee extension lag. Another study went further to report a greater fall rate with older age populations. They did find that diabetes is not associated with worse functional outcomes. And with 5 out of the 6 moderate quality studies, they reported a greater degree of comorbidity as a factor related to worse patient reported outcomes on the WOMAC. For male and female, they found that it may or may not be related to either positively or negatively affect the recovery after a total knee replacement. And like I mentioned before, the article did note that there are other prognostic factors out there, but they might not have been described to have an effect on patients' outcomes. This was just what they found from all the studies that they put together. So the benefit of noting these prognostic factors is that patients and PT practitioners can analyze and discuss the potential effects that these factors might have on that individual following a total knee replacement. And again, there was no risk or harms associated with this recommendation. Post-operative physical therapy supervision. So the recommendation is that supervised physical therapy management should be provided for patients who have undergone a total knee arthroplasty. The optimal setting should be determined by patient safety, mobility, environmental, and personal factors. So this recommendation had a moderate evidence quality and a moderate recommendation strength. They found in the article discussed that in one moderate quality study, they randomized 40 individuals to either a supervised program that met twice a week for 1 month, or a supervised program that only met twice a month and performed home exercises. They found that the more frequently supervised group had better self-reported outcomes, mobility scores, and balance at the end of the intervention compared with the less supervised group. So this made me think to sometimes having a patient that comes in and they seem to be performing well and better off, and we kind of decide, is this patient qualified to be in PT now, or should we kind of discharge him a little bit earlier? But I think this really did a good job of illustrating that even if someone might be a little bit better off, that PT should be utilized and be provide more supervision so that we can accurately progress these patients with their home and strength routines. But they said that they would like for us to have more research to identify what individuals might actually succeed with less structured supervised rehab before discharging them from whatever facility that they are currently in, whether it be hospital or outpatient or any other setting in between. And there were no risks associated with this recommendation. But the benefits, again, physical therapists can produce a better outcomes with these patients if they provide more supervision so that they can appropriately and safely progress their exercise routine. And lastly, I'm going to talk about is outcome assessments. So the evidence for this was insufficient, but this is recommended as best practice. Physical therapists should collect data utilizing the knee injury osteoarthritis outcome survey joint replacement as a patient-reported outcome measure, and as collecting data from a 30-second sit-to-stand and a tug as performance-based outcomes to demonstrate the effectiveness of care provided. At a minimum, these measures should be collected at the first visit and upon conclusion of care from each setting. So the group decided that this is a recommendation that we should be putting forth. There is evidence for the reliability and validity for the use of these tools in the population of patients with total knee arthroplasties. They found that there is internal consistency for the knee injury osteoarthritis outcome survey, and that it was high and had a good correlation with other validated knee surveys, and it was excellent. They also reported excellent inter-rater and intra-rater reliability for the tug test. They also said that the 30-second sit-to-stand test had an excellent test-retest reliability, but the validity for this test has not been established for patients within this population, and that there is a need for more research within that area. Overall, because there's insufficient research already out there for appropriate outcome measures for this population, they are pushing the need for more consistent outcome measures to improve the understanding and effectiveness of care that is being provided for these patients. So the benefit of this recommendation is that we are getting the documentation for our plan of care. We're trying to establish consistent measures across the continuum of care. It's minimal time to administer, and we can utilize this information for other healthcare providers to also understand. And they noted that there is no risk for having these tests be implemented, but it might increase the time to perform these outcomes. On this next page, I included just a quick screenshot of the questionnaire that the patient would be receiving for them to check off, rating how they view their knee has affected their ability to do their daily activities, their pain, and their overall feeling of stiffness. And that is the end of the presentation. If you have any questions, feel free to jot them below in the post or send me an email.